This film shows the treatment of one little boy with atypical clubfoot. Atypical clubfoot responds differently to treatment compared with idiopathic clubfoot. In order for treatment to be successful, atypical clubfoot should be identified early and treatment modified from the standard ponseti technique. In this film, we will show you how to identify and treat an atypical clubfoot. Cast 1. This is baby Guy. He was born at 38 weeks gestation with bilateral club feet, both scoring 6 out of 6 on the Pirani score. He presented to Chelsea and Westminster Hospital at 12 weeks of age. Prior to this, he had started ponseti treatment at another centre. There, he had 6 casts, the last of which had slipped. He was recognised as having atypical clubfoot and referred here for treatment. Guy is starting treatment today following 1 week out of casts to allow time for the skin to heal and swelling to reduce following the cast slip. Before commencing treatment, a full assessment of the baby is carried out, and the clinician explains the treatment to the parents. The Pirani score is used to grade the severity of the deformity. It is essential to observe the foot from all angles, the top, bottom and sides. The score for medial crease is 0.5. There is severe cavus deformity extending across the foot, as is commonly seen in atypical cases. The score for curvature of the lateral border is 1. The metatarsals deviate into abduction from the calcaneo-cuboid joint. Next, the lateral head of talus score is measured. To find the lateral head of talus, the thumb is placed on the lateral malleolus and moved anteriorly by approximately 1 centimetre. The clinician moves the front part of the foot in and out of abduction in order to feel how much coverage there is of the lateral head of talus. In this case, as with most atypical feet, the medial structures stretch relatively easily, allowing movement into abduction. The score for lateral head of talus is 0.5. The posterior crease is deep, scoring 1, and indicating that the structures in the hind foot are very tight. In order to assess for empty heel, the heel is palpated from a 45-degree angle. The score for empty heel is 1. There is extreme tibio-talar plantar flexion, and the score for rigid equinus is 1. The total Pirani score is 5 on both sides. Having measured the Pirani score, there are a few additional features of the feet that identify them as being atypical feet. The first is the patient's response to treatment. There is not much reduction in the Pirani score even after 6 casts, and at least 1 cast has slipped. The feet are short and wide. The big toes are small, shorter than the second toes, and are tight into plantar flexion. There is hyperextension of the big toes, indicated by a crease across the dorsal surface of the toes. There is cavus that extends across the plantar aspect of the foot. In many atypical cases, this gives rise to a transverse crease that extends fully across the foot. The tibia appears bowed, and there is extreme tibio-talar plantar flexion. After assessing the feet and identifying that they are, in fact, atypical club feet, the clinician plans her treatment. The first ray will be elevated in the first cast in order to reduce the cavus, which has recurred in the week spent out of cast. This is the same as would be done in an idiopathic clubfoot. As well as elevating the first ray, the foot is also elongated in order to stretch the tight medial and plantar structures. Just before the cast is applied, a few more manipulations are performed in order to stretch the foot. The lead clinician has the role of manipulator and is directing the treatment. She will manipulate and hold the foot and mould the cast. The caster, who is wearing gloves in order to identify him, will apply the cast. The manipulator holds the foot by the toes and the knee in order to allow space for the padding to be applied. The cast underwrap or padding is applied in a thin layer. As these feet are at risk of slipping in the cast, the below knee section is applied first in order to allow maximum control of the foot. A foot plate is applied in order to allow moulding of the plantar surface and to support the toes. The wet plaster of Paris is applied whilst the manipulator continues to hold the foot in position. Plaster is applied in 3 layers, adding some tension in order to make it snug around the ankle. After the caster has wrapped the plaster on, he stabilizes the knee, allowing the manipulator to hold the foot in position and mould the cast. As the plaster sets, the foot is moulded into elongation and supination of the first ray. The manipulator maintains this position while the cast dries. The manipulator moulds the cast well behind the heel in order to prevent the cast slipping and stretch out the posterior crease. Once the bottom section of the cast is set, the padding is extended above the knee, as high into the groin as possible. A front slab of plaster is applied over the knee to reinforce it, and so that not too much need be applied behind the knee. The caster applies the top section of plaster, starting from the groin and working down towards the knee. The knee is bent to 110 degrees. In atypical cases, it is especially important to be aware of the position of the knee and tibia as the cast is applied, and to avoid causing further tibial bowing. The plaster above the toes is cut back so that all 5 toes are visible. In cases of cast slip, cutting right back above the top of the big toe can prevent further slipping, as it stops the baby flexing the toe up inside the cast and pushing the cast down the leg. The first casts on both legs are completed. The features of the cast that will help prevent further slipping are the moulding on the plantar aspect and behind the heel, the thin padding, and plaster allowing the shape of the foot to be clearly seen, the flexion of the knee to 110 degrees, and extending the casts high up the leg. After the casts are applied, it is important to explain to parents that they must look out for cast slips. If the cast does slip, they must make contact with the clinician and it should be removed straight away. Cast 2. Guy returns for his second cast 4 days later. Where possible, twice weekly cast changes can help to reduce cast slips. First, the manipulator assesses the progress in the foot and records the Pirani score. The total Pirani score is now 3 on the right and 4 on the left. The cavus is starting to resolve. In this cast, the manipulator will focus on elongating the plantar structures in the foot. To do this, she will use a modified handhold for manipulating the foot and moulding the cast. This is known as the atypical maneuver. The hind foot remains very tight. There is a lot of excess skin over the lateral side of the foot. The parents are reassured that this is normal and that it will resolve in time. The cast is applied holding the foot in midline. Further abduction is avoided. Continuing to abduct the foot may cause a mid-foot break and is not necessary in the atypical clubfoot once the lateral head of talus is fully covered and the heel is in neutral or slight valgus. The manipulator uses the atypical maneuver to mould the cast. Both thumbs are placed on the plantar surface of the foot. As the cast sets, the foot is elongated and the plantar surface stretched to reduce the cavus. The medial thumb is higher, keeping the foot in slight supination. The fingers on top of the foot are very lightly touching the top of the cast, and the manipulator is able to lift and move these to avoid creating an indent. The features of the casts for the atypical clubfoot are moulding on the plantar surface of the foot and behind the heel. The foot is in midline. Abduction is minimal. The knee is bent to 110 degrees to prevent cast slips, and the cast extends high into the groin. The parents are instructed to support the casts when carrying the child. Cast 3. The cast was changed once more prior to the tenotomy. At this point, the Pirani score was 2.5 on both sides, and all midfoot scores had reduced to 0. Note the position in the third cast. The cavus has reduced and dorsiflexion has increased. The toes have come forward in the cast, and there is only a few degrees of abduction. Cast 4. The team decides whether the baby is ready for Achilles tendon tenotomy. The across-foot cavus has gone. There is a very slight medial crease visible, but it does not alter the contour of the foot, and the lateral border is straight. The heel has moved from varus into slight valgus. The lateral head of talus is now fully covered. Further abduction would risk causing a midfoot break, indicated by the formation of a lateral crease when abducting the foot. The hind foot remains inequinous, and the heel feels very empty. The Pirani score is 2.5 on both sides. The team agree that the patient is now ready for the Achilles tendon tenotomy. The surgeon determines the position of the tenotomy, approximately 1.5 centimeters above the top of the calcaneum. The first attempt to divide the tendon is slightly too medial. The surgeon revisits the tendon to check if it's completely divided, passing the scalpel more laterally. The foot immediately moves into dorsiflexion. Pressure is maintained over the tenotomy site for a full 5 minutes, with the foot and ankle held in dorsiflexion. The left Achilles tendon tenotomy is also successful in increasing dorsiflexion. After the tenotomy is finished, the legs are again put into plaster with the ankles in maximum dorsiflexion. The manipulator determines that a little more range of dorsiflexion will be needed in order for the feet to fit comfortably into the foot abduction brace. She therefore decides to do one more change of casts after 1 week. The foot abduction in the casts is still minimal. 10 degrees is enough. After all this, it is time to relax. 3 weeks after the tenotomy, the final casts are removed. The tenotomy site is well healed. The feet are now in a much improved position. The cavus and adductus have resolved, and the crease on top of the big toe has stretched out. The medial and plantar tightness are no longer apparent, and there is good evertor muscle activity when tickling the foot. There is dorsiflexion just past neutral, and the posterior crease has gone. The Pirani score is 0. The feet are now in a position where they will easily fit into a foot abduction brace. The foot abduction brace is measured and fitted. The angle of abduction is set to just 30 degrees. This can be increased later as the range of motion into abduction naturally increases. The heels are fully down in the backs of the boots. The foot abduction brace will now be worn for 23 hours out of 24 for 12 weeks, and then at night and nap times until 5 years of age. It is important that the parents are aware that the baby may be unsettled for up to 48 hours after the first brace fitting. In the early stages of brace use, families need a lot of support to help them become confident with the brace. These are Guy's feet 3 months after tenotomy. He is wearing the foot abduction brace well, and the feet are looking very well corrected. With early recognition, attention to detail, and a few modifications to the standard ponseti technique, babies with atypical clubfoot can have very good outcomes.